This is TTT Live. I'm DK Rostar. The Ministry of Health is giving an update on the status of COVID-19 in Trinidad and Tobago. We're bringing you live coverage on TTT, Chalk City 91.1 FM, and on Facebook at TTT Live Online. We go now to the Senior Corporate Communications Officer at the Ministry of Health, Al Alexander.
Christine Carrington, Professor of Molecular Genetics and Virology, and Nurse Grace Suchan, Expanded Program on Immunization, Ministry of Health. I am Al Alexander, Senior Corporate Communications Officer at the Ministry of Health, and I will be the moderator for today. Dr. Avery Hines will begin with the latest clinical update and epidemiological report.
Thank you, Mr. Alexander. Good morning to my colleagues, Professor Carrington and Sukhchand. Good morning to members of the media, members of the viewing and listening public. The clinical update for the date November 29th, as at 4 p.m., is as follows. As at that date and time, there were 36,732 unique individuals tested. Of those, 6,660 tested positive, and of those, there had been 120 deaths, and we extend our condolences to the members of the bereaved family. There are currently 795 active cases in the system, broken down as follows. There are 42 persons in hospital. There are 29 individuals in step-down facilities. There are 694 individuals in self-isolation, including the cohort that would have arisen out of the prison system. And the additional 30 corresponds to the new cases that would have been identified over the 48-hour period preceding this update. There are 306 individuals at this point in time in state quarantine facilities. I'm going to move straight into the epidemiologic update, so can we put up the slides? As at November 29th, next, we have the epidemic curve, which shows the samples by date of collection, next. And what we see is the months from July through to November, July in blue, August in purple, the September in dark blue, October in green, November in orange, and a black line running through that graph, which represents what we call the 7-day rolling average. And we do see that in spite of two, what we might refer to as spikes that actually correspond to increased cases arising out of the cluster from the prisons, the 7-day average over the last few days has now begun to drop back to the normal, or back to what is baseline at this point in time for our population, which is about 30 cases per day. Next slide, please. The demographic characteristics, that is the age and sex and geographic distribution, are as follows. We do see that we have about 54% of the positive cases being men, and out of the total number of cases, the majority are in the 25 to 49 age group, that being just about 55% of all the positives. Next slide. Among the deaths, the distribution is different. We do see that men make up approximately 3/4 of those who have passed on, and that more than 2/3 of those who have passed on are above 60 years of age. But we do note that individuals below 60 years of age are not exempt or immune from adverse outcomes, and we have seen those, especially in persons with underlying conditions, pre-existing medical conditions, such as diabetes, such as hypertension, such as chronic immune issues. All of these have contributed to adverse outcomes, and we want to take the opportunity at this point in time, again, to encourage everyone to adhere to the public health regulations and guidelines to reduce the risk of spread. Next slide. The geographic distribution that we show today is showing the activity over the last 14 days, thereabouts, where the lightest yellow color shows the communities with no cases, and the darker colors moving from yellow into red show communities with increasing numbers of cases. You will note that there have been new cases across all the counties, but not evenly distributed throughout all communities. So some communities were a little more active than others. If you can see the blue outlines around some of the communities, those would be the ones where there was activity in the most recent week, the past 7 days, but not in the week before. So we've modified the geographic display to show the more recent, the more active case distribution, as opposed to all the cases from the start of the second phase go forward. That's the end of the presentation. At this point, I do just want to reiterate one of the important messages that the Minister of Health has been emphasizing, and that is that as we move into the festive season, the Christmas season, we do want to continue to encourage all members of the public to avoid what we would traditionally do with regard to having gatherings, office limes, household limes. We want to reduce the risk of bringing webs of people together, and in so doing, we want to reduce the risk of transmission of this virus from people who may not know that they are ill. So we want to encourage the virtual hangouts, virtual limes. We want to encourage people to remain indoors. We want to encourage people to maintain the hygiene practices that we've been advocating, the wearing of the masks, the washing of the hands, the physical distancing, and the avoidance of gatherings, especially if you are unwell. Anybody who's having any kind of respiratory symptoms, again, we encourage you to stay away from work, stay away from class, stay away from gatherings. If you are having more severe symptoms, if you're having any sort of difficulty breathing, shortness of breath, any sort of discomfort, then you reach out to the public health system and they will provide guidance on what to do next. You can call the hotline, you can call the county medical officers of health for guidance on the next best step. If you're having any sort of emergency, severe shortness of breath, collapse, extreme fatigue, then you can go directly to the emergency rooms declaring that you have respiratory symptoms, and they will put you through the appropriate channels to have your symptoms and your situation dealt with while still reducing the risk of spread within the institutions. So we want to leave that message uppermost in persons' minds. We have to hold the line and maintain the activities to reduce spread as we move into the festive season. Mr. Alexander.
Thank you very much, Dr. Hines, and especially for the guidance that you would have just given to the members of the public. Similar to our last COVID-19 update on Saturday, this media conference will also focus on the importance of vaccines and explain why it is so important for members of the public to be immunized against contagious diseases, such as the flu and COVID-19. Professor Carrington will now provide more information on this topic.
Thank you, Mr. Alexander, and good morning to the members of the media and the viewing public. Now, vaccines are among the most important public health interventions that we have at our disposal, and an effective vaccine against SARS-CoV-2, the virus that causes COVID-19, is thought to be the only long-term solution for controlling the COVID-19 pandemic. There are currently about 300 vaccines in development worldwide, and 56 of these are in clinical trials, meaning that they're being tested in humans. Now, there's no vaccine candidate that has been fully completed its phase 3 vaccine trials, but recently there were announcements about very positive results from interim analyses of the trials of 3 vaccine candidates. Two of these are mRNA vaccines, and the third is a viral vector vaccine. And in each case, the interim analysis that they did indicated large reductions in disease in individuals who had received the vaccines compared to those who had not. The results are extremely promising, and we look forward to revisiting them once the trials are complete. So these are interim results. Now, as usual, there have been an avalanche of very convincingly packaged misinformation in circulation, particularly about the mRNA vaccines. And my aim today is to provide information on the different types of viral vaccines in use and in development, not just for COVID-19, but in general, so that everyone is sort of better equipped to understand COVID-19 vaccines and how they work and different strategies that we can use. We'll start with a little background on viruses and the immune responses to them. Can I have the first slide, please? Okay. So viruses are tiny infectious particles that can only replicate inside of living cells, the living cells of an organism. On the left in this slide is the structure of a typical virus particle. They consist of basically a piece of genetic material, and that's indicated by the little red squiggle. And that genetic material is surrounded, which it can be DNA or a molecule called RNA, and that genetic material is protein cloth, which is the blue part that you're seeing there. There are some viruses, including the SARS-CoV-2 virus. As I said, that's the virus that causes COVID-19. They also have a lipid envelope around them, so they have an additional layer. Now, if you look on the right now, the virus's genetic material or viral genome is basically a set of instructions for how to make more viral particles. So the main function of the virus particle is to deliver its genome, to deliver those instructions into a host cell where, with the help of the host cell's machinery, it can be used to make new virus particles. So this is how an infection spreads from one cell to another, from one tissue to another within the body. So the figure on the right illustrates how once the virus genetic material enters the cell, it reprograms the cell to produce more virus particles. You have steps 1 and 2 at the top left of that figure, showing the virus attaching and then entering the cell. In step 3, the viral genetic material, which as I said is shown in red, instructs the cell to make viral proteins, and those are shown by the little blue blobs. At the same time, several copies of the viral genome are made, and then the next step, step 4, the genome and the proteins, they assemble together into new virus particles, which are then released from the cell to infect new cells. Now, why I'm telling you all this is because when an infection occurs, the body recognizes those virus particles and viral proteins as foreign invaders and mounts an immune response against them. Can I have the next slide? So this immune response involves sizing up the invader and then selecting and mass-producing specific immune response cells called B cells and T cells. The B cell is shown in blue and the T cell in dark gray. B cells, as shown here, the blue one, they make antibodies that bind to and block the target virus from infecting new cells and replicating in them. And some T cells, the T cells, they're different types, and one type kills infected cells. So the circle shown in the diagram with all the little blue pieces inside of it, that's an infected cell producing virus and producing virus proteins. That would be targeted by T cells. Now, all of this immune response reaction, that takes time. And while that is occurring, you can have damage occurring to tissues and disease occurring. If the immune system wins, then the virus is cleared. There are occasions when the virus wins and obviously the organism suffers. Now, importantly, the immune system remembers viruses that it has seen before. So when it encounters them again, the immune system can go into action much more quickly than the first time and prevent the infection from taking hold, or at least prevent it from causing illness or spreading to another person. So this is what is meant when we say that somebody has developed immunity to a particular virus after being infected by it. Can I have the next slide, please? Right, so vaccines now are biological presentations that train the immune system to recognize and combat specific infectious agents by triggering an immune response without causing any disease. Put simply, what they do is they trick the body into believing that it has been infected by presenting it with similar or modified virus or proteins from the disease-causing virus. So you're tricking the body into believing it has been infected, and it mounts an immune response that it's now going to remember in future should it really get infected by the disease-causing virus. And there are various strategies for doing this. So I've shown 3 of the main ways here. So on the left, the big the pink circle with the blue inside, that is illustrating a type of vaccine where you use a whole virus which contains the proteins of the target virus, but it does not cause disease. The other alternative, to the top, is where you use only the proteins of the target virus, which by themselves cannot cause disease. And the third option is using part of the genetic material of the target virus, so not all of the genetic material, just part of it, which carries instructions for making the viral proteins that the immune system is going to respond to. Next slide. So how is it possible to get a whole, we look at the first strategy, how is it possible to get a whole virus that looks like a disease-causing target virus but does not cause disease? One way, the top left, is to use a live attenuated virus, which is basically a weakened or a similar version of the virus you want to target. It can infect cells, it replicates in those cells, but because it is weakened, it does not cause disease. A good example of such a vaccine is the yellow fever vaccine, and also the vaccine for chicken pox is also an attenuated virus. There are others as well. Alternatively, you can kill or inactivate a disease-causing virus and use that as a vaccine. So that's on the bottom left. These are called dead, killed, or inactivated vaccines. They can't infect cells, they can't replicate, but the proteins, although they're damaged, are still recognizable enough to the immune system that it will trigger an immune response that is specific to your target virus. An example of such a vaccine is most of the influenza vaccines are like this, and the injected version of the polio vaccine is also an inactivated vaccine. Then on the top right, you have your live attenuated recombinant vaccines. In this case, you take a totally different virus from the disease-causing virus, one that does not cause disease. And in this example, the virus we're using is a green virus, and it has yellow genetic material, and you modify it. Now, obviously, it's not literally green and yellow. I'm just using that to illustrate. So we have a green virus with yellow genetic material, and we've modified it by inserting part of the disease-causing virus's genome. So the little piece in blue is from the virus that you want to target, and that little piece encodes the information for how to make the protein that the immune response is going to see and mount a response to. So this virus can infect cells and replicate, but since it only has part of the disease-causing virus's information, it does not cause disease. And since it carries the disease-causing virus's proteins, and shown on pink on the outside, the immune response is specific to the disease-causing virus. The Ebola vaccine that they have one of them they have in use now is that type of vaccine. Then finally, we have the ones that are newer developments. We have the viral vector vaccines. These are similar to the ones above, the one I just described, the recombinant one. But in this case, the green virus, the backbone virus we're using, that's delivering the disease-causing virus's genetic material, it doesn't, the proteins on it are not of the disease-causing virus. It's simply a little transport pod, basically, for the genetic material of the virus that you're targeting. So this can introduce that genetic material into a cell, but it doesn't replicate and it doesn't cause disease. Next slide. Next slide, please. Right, in this strategy now, this is the one where we're only using the viral protein, so no genetic material involved here. And you can, in some cases, what you do is you produce the viral proteins without the rest of the virus. You purify those proteins, and that is your vaccine. In some cases, they produce the viral proteins in a way that they assemble to form little virus-like particles, and to the immune response, it looks just like a virus, and so sometimes you get a better response to that type of vaccine. And these vaccines can't infect cells, so they're not good at eliciting a T cell, what we call a T cell response. Hepatitis B vaccine and the human papilloma virus vaccines, they fall in that category. And then finally, next slide, you can use just a small part of the genetic material from the disease-causing virus, not the whole genome of the virus, just the part that produces the viral protein that will trigger the immune response. And when this genetic material is delivered into a cell, the cells produce the protein and the immune response is triggered. Next slide. Right, so let's turn now to the COVID-19 vaccines. As I mentioned before, there are 3 COVID-19 candidate vaccines from which interim data on efficacy has been obtained recently. All 3 of them contain SARS-CoV-2 genetic material, and that's shown in blue with the arrows pointing at it. And that genetic material instructs, if that is delivered to a cell, that instructs the cells to produce that virus protein. That protein is called the spike protein, and it's extremely good at eliciting an immune response. So once it is delivered, the spike protein is expressed in the cell. It's seen as foreign, and that triggers an immune response that is specific to SARS-CoV-2. So if the immune system is ready should SARS-CoV-2 actually infect the individual. The candidate vaccine from Oxford AstraZeneca, shown on the left, is a viral vector vaccine. The backbone, so the yellow and green part of it, is a chimpanzee common cold virus called an adenovirus. So it's a virus that normally infects chimps, and it would cause common cold in them. However, it has been modified so that it does not cause disease and it cannot replicate in humans. And all it does is deliver that SARS-CoV-2 genetic material into the cell at the cells that are at the site of injection, and those cells then produce the spike protein. One of the advantages of this version is that it can be stored at in a fridge at about 2 to 8 degrees Celsius. It's fine, and it's also I think it's at a lower price as well. The last one, if we go back to the slide, the Pfizer and next slide, please. Right, so the Pfizer and Moderna vaccines, those are mRNA vaccines, and that's shown on the right. So that is simply a small piece of RNA that encodes has the information for how to make the spike protein. RNA is not very readily taken up into cells, so what they've done is they've packaged it in a little lipid bubble called a lipid nanoparticle, a lipid nanoparticle. Those, once it's injected, it goes into the cells. It cannot replicate, it cannot cause disease, but once it's in the cell will produce the spike protein, and that stimulates the immune response. One of the difficulties with this one is that RNA is very fragile, and despite the modifications that they've made, it does have to be stored at low temperatures. There's one of them, the Moderna vaccine, I believe, which they say can be stored in a fridge for a limited amount of time. Now, these two are a little more expensive. Now, to end, I just want to reiterate that none of these candidate vaccines have completed their phase 3 trials. So we have to wait for that to be completed to get the full data, but it's going to happen very soon, I expect. The results are so far immensely encouraging, since there have been no significant side effects in the tens of thousands of people in the trials, and they do appear to be giving good protection. Thank you.
Thank you, Professor Carrington, for quite a detailed and informative presentation. I now invite Nurse Suchan to update you on the status of the flu vaccination campaign and the plans for COVID-19 immunization.
Thank you, Al. Good morning again to Dr. Hines, Dr. Carrington, and to the viewing and listening public. So, following on Dr. Carrington's presentation, this is just to inform you, the population, on where we are with respect to preparation for the COVID-19 vaccines. At a high level, Trinidad and Tobago have signed on to the Gavi facility. The Ministry of Health has been in discussion with Gavi since July of 2020, and a commitment letter was signed with the COVAX facility on the 23rd of September 2020. Operationally, Ministry of Health received correspondence from Gavi on the 19th of November 2020 requesting the focal point for the vaccines. The Ministry of Health responded 24 hours later on the 20th of November 2020, appointing 2 focal points. Myself, EPI Manager, as the focal point for the receipt, storage, and distribution of the vaccines, and Ms. Sibu, the Principal Pharmacist, as the focal point for the COVAX facility. As manager of the EPI program, I can say with confidence that Trinidad and Tobago has always had an effective and robust vaccination program. When we look at our coverage rates, as well as our successful immunization program with respect to vaccines such as measles, polio, tetanus, yellow fever, we can see that we have been working assiduously to maintain the coverage as well as vaccine preventable diseases in Trinidad and Tobago. In 2016, we were certified measles free. And although the world had an outbreak, thank God, because of our strong, robust program and the commitment of healthcare workers out at the facilities, we have managed to keep that in check and not have an outbreak. As far as COVAX vaccines are concerned, we would be building on the platform which have been successful. However, depending on the characteristics of the vaccines approved, we would make the necessary adjustments. Rest assured that the Ministry of Health have been going through scenario planning for this vaccine. The Ministry of Health has established a committee for planning, coordinating, and implementation of all activities related to the rollout of the COVAX vaccines. We review global level information from WHO, UNICEF related to COVID-19 vaccines and have incorporated it into planning and preparation as needed. We have elaborated the deployment plan with clear functions, responsibilities, and deadlines for all persons involved in this committee. Establish an operations room for coordination, information, and communication. Take final responsibility for implementing activities. Report to higher level authorities when required, and communicate with the partners and, of course, the press. We have identified 3 sites for the storage of vaccines, 2 in Trinidad and Tobago, namely Couva, as well as Central Stores, and 1 site in Tobago. Chillers are going to be installed to prepare for these vaccines. We would also be, in the event, if needed, we would be sourcing ultra-low freezers. Of course, we have our human resource management and training of staff and of health facilities where these vaccines for the phase 1 would be rolled out. Okay, and that's basically it for the rollout of this COVID-19 vaccine. Back to you, Al.
Thank you, Nurse Sukchan. We now move to the question and answer segment. We once again remind our media representatives to state your name and the name of the media house that you represent before asking no more than 2 brief questions. Please ask both questions, one right after the other, to the relevant members of the panel. If time permits, we will facilitate a second round of questions, 1 question per media house. Today, we begin the Q&A with questions from CNC3.
Morning, everyone. Rashad Khan, Guardian Media Limited. My question this morning is to Dr. Hines. So you indicated that right now our rolling average is around 30 cases a day. Can you say whether these are, like last time what you stated, predominantly cluster cases you're seeing happening between families interacting with each other and at workplace, or are we kind of seeing more now of community spread?
Is there a second question? Okay, thank you.
Okay, thank you for your question. We never moved out of the community spread phase or distribution of cases. What we did note is that among the cases that were in clusters, those clusters tended to be related to gatherings and family events, and we used that opportunity to re-emphasize the importance of avoiding those sorts of situations because they were one of the drivers of spread. So we do see clusters that are related to gatherings both in families and outside, and we also note that there are still cases that arise without an identified or identifiable exposure, likely due to exposure to a mildly symptomatic or even an asymptomatic individual. So we're still seeing both patterns of occurrence at this point in time.
Thank you very much. We now go to TV6. TV6.
Hi, good morning, everyone. My question goes to Professor Carrington. Have we been testing for antibodies? If yes, at what rate of those tested show antibodies? And if no, are we going to make the decision to test for antibodies to determine who would need vaccinations for COVID-19 versus those who won't? I'm asking this as I'm seeing that this is a novel virus. Can we say whether it will be safe to vaccinate someone who already has antibodies?
Okay, thank you. Unfortunately, I am not the person who can answer questions about whether there has been population-level serological testing. It has not been as far in terms of UE, where we haven't done any. But someone else will have to answer that question for you.
Okay, let me take the add-on to that response. The antibody testing approach has not been utilized at this point in time within the Trinidad and Tobago's testing strategy. We have been utilizing the PCR testing, and we have been looking at rolling out the antigen testing as an additional layer of testing capacity, but not yet the antibody testing, because again, we are looking at testing to reduce the risk of spread in active cases, and antibodies actually only show up later on in your disease process and therefore aren't the appropriate test for the strategy currently being employed. So I hope that answers your question.
Thank you, Dr. Hines. We now go to YL868. YL868, are you there?
Hi,
Good
yes.
morning.
Morning, everyone. My first question is to Dr. Carrington. Given the speed at which these vaccines were created, it was kind of unusual. When you compare to vaccines in the past, the time taken to get to these trials. Given the speed, how safe do you think the population can feel about the safety of these vaccines? And if people are going to be getting them voluntarily, at least the 33% that we will be vaccinating in the country, how will they be getting it voluntarily, first of all? And how will they be guaranteed their safety, or at least assured their safety? That's for Dr. Carrington. And now for Dr. Hines, we spoke sometime about the fatigue, the COVID fatigue that people have been feeling now. And since you said that the vaccine would only be an extra tool and not really getting herd immunity for the entire population, how exactly, what targets can the population look forward to the end of the measures that we have to be taking in terms of when we will be able to get back to normal, when the borders will be open, when we will stop having to wear masks, when the schools will be open? Like we're at 30 new cases now, the rolling average. What are we looking for? What targets are we looking for where we could see that, okay, we're going to see some level of normalcy return, and even with these vaccines and an additional tool, we can start getting back to normal?
Okay. So I'll go ahead and start. So your question is about the speed at which the vaccines have been created. So the first thing to understand is that we didn't start in a vacuum. Scientists have expected for a long time, based on the way that man has been treating the environment and the how things have changed in our around us, and given that we had already started to see viruses emerging regularly, there were scientists out there, there were people out there who were preparing for having to launch, going to make a vaccine very rapidly. So there was a lot of work that had been done before on previous coronaviruses, and that helped inform the response and sort of gave people a head start. Also, in terms of strategies for making viruses, there was also a lot of work done, and a lot done specifically with the with a view to coming up with strategies where you can pivot very quickly to make a vaccine for a new virus. So that was in place. So we had a head start. Secondly, even when it takes a very long time to make a vaccine, 10 years, a lot of that time is downtime. It's time spent writing grant proposals. It's time spent getting money. It's time spent getting approvals. It's time spent, you're just waiting a lot. So apparently in this case, what has been happening, because everybody is so focused, all the authorities, all the governments, all the people involved, all the stakeholders are focused on this one goal. That movement from one stage to another, all that downtime has been cut out. So there's been no shortcuts taken. It is just cutting out, making it more efficient to go from one way to from getting from point A to point B. The other point is, I touched on it, money. Often a lot of this is slowed down because there's not enough money to do what you have to do. I read an article where the Oxford vaccine, the vaccine was being the vaccine for the trial was being manufactured in Italy. With all the travel restrictions, they had to try and get the vaccine from Italy into the UK. And there was a time when they would not have had money to charter a flight to carry some vaccines over. That is not an obstacle. So having the money there is also a big help. And as I said, the last thing, everybody focused on the same thing. So in going through the steps of testing these vaccines, there have been no shortcuts taken. It's just that the whole process has been more efficient. Also, this particular virus is, there's some viruses where it's difficult to find the right protein to use in a vaccine because the protein is very variable. It changes over time. Or because it's a type, sometimes you have viruses which hide from the immune system. So like HIV is a good example of that. So this virus, however, is luckily, if there's anything lucky about it, luckily it seems to have been a relatively easy target. The spike protein seems to be it's very immunogenic, and it seems to antibodies against it provide good protection. So it's a combination of organization, preparation, and some serendipity.
Okay, thank you for your question. I'd like to take the opportunity to clarify something that may have not been well understood in the response that was received about the 33% coverage, which you asked about. I believe you had asked the question yourself, what the strategy was with regard to the target of 33% or so for the vaccines that were being brought in this first phase. And what we emphasized at that point is that target would then be looking at the vulnerable populations and covering and protecting those who were exposed or vulnerable first, in the first phase. There will, of course, be additional phases of vaccination, additional phases of vaccines being brought in, aiming at greater coverage. So it is not that the only strategy or the be-all and end-all of the strategy is just to target that initial percentage and look at vulnerable individuals. There is additional coverage to be had and to be generated by second and ongoing phases of vaccination. Now, the question about whether when we are looking at going back to normal, what targets we're setting and looking at the 13 new cases per day, again, the opportunity arises to point out that the reason that we're at 30 new cases today as opposed to 50 or 60 or 100 is because of the measures and behaviors that we've put in place and we've been asking people to adhere to, and which to some extent that has been acknowledged and has been followed. The 30 per day number or rate is therefore not something that you'd use to say, okay, we've reached here, so now we can pull back, because it is dependent on the behavior of the population. As you rightly pointed out, the vaccine is an additional tool, it's an additional layer of protection that we want to provide to the population, but it still goes along with the behaviors that we've been emphasizing as part of the new normal. So when you say going back to normal and taking off the masks and those sorts of sort of retrograde steps, moving in the backward direction. That is not something that we are aiming at as part of the new normal. I'll give you an example. The 1918 influenza pandemic went on over a 2-year period. It went on over a 2-year period and went in several waves. So the time span for looking at how we return to less stringent measures is going to be determined over a lengthier period than just the next couple of months, even lengthier period than when the vaccine first comes out. You have to see what kind of numbers come out in the population, see what additional improvements those vaccines make to the rate of spread, and then we can get a clearer idea of how close to the end of the tunnel we are. So where the fatigue is concerned, we do understand that doing things differently does create some level of stress and some level of tiredness with having to do different things and maintain a higher level of vigilance, but it is going to continue to be necessary, at least for the foreseeable future, while we try to protect our population in all the various ways that are possible. And those ways include the regulations as well as the vaccines. So I hope that brings a little additional clarity to the question.
I know Ms. Bostic asked the question, given the speed at which the vaccines will produce, will they be safe? Could we have that question addressed?
Okay. Yes. So when you're doing these vaccine trials, part of the purpose one reason you do them is to see if the virus works. But long before you reach these phase 3 trials, you have other stages of trials where you're looking specifically at safety, and you're looking to see, when I give this vaccine to a person, do they have any immune response? Not immune response, any adverse response. And so far, for all the vaccines we've been discussing, this has been, they appear to be very safe. Or else they would not have put them into 30,000 people for the phase 3 trials if they weren't confident that they were safe. You still get the trial that's going on now, you're still getting safety information from that as well, because you put it into a larger number of people. But by the time the vaccine is approved, they'd be looking at a very large pool of information with tens of thousands of people, of volunteers, to determine if the vaccine is safe, and the vaccine will not be approved unless it reaches a certain threshold of safety. So if it comes, it'll be safe.
Thank you very much, Professor Carrington. We now go to CL Communications. Thank you very much, Professor
Hi, good morning. Natalie Singh, CL Communications. I just wanted to find out concerning the prison system. Now that there have been cases that have surfaced coming from there, has the Ministry of Health actually took a team to the prisons to make sure that all the protocols are in place? And if so, well, what sort of measures have you done, or what have you done with regards to making sure that the preventative systems are in place within our prison systems? And secondly, concerning the vaccines, would prisoners also be having access to those vaccines too? Thank you.
Okay, thank you for the questions. As we had indicated before, the prison medical response is actually within the remit of the prison system itself. They have the prison's medical officers and systems that are the ones responsible for implementing all of the preventive measures. The Ministry of Health, via the county medical offices of health, will then just provide the technical guidance. We can provide additional information on how best to implement protective measures, but the need to visit the prison as a Ministry of Health team does not arise, as we are not the ones directly administering that prison health system. So while we have provided the information on how best to implement the quarantine and the isolation measures, and that those instructions have to a large extent been received and implemented, the Ministry of Health doesn't then go into the prison to do an audit, so to speak, of the process, because that is outside of our direct remit. with respect to the prisons and the prisoners being vaccinated, the strategy for the first set of vaccines that will be received is targeting vulnerable individuals in the general population. As additional vaccine is received, then policies and strategies will be elaborated to cover the wider population, and at that point in time, more information will be provided on what the next phase and what the targets for the next phase will be.
Thank you very much, Dr. Hines. AZP News, you are next.
Hi, good morning. Priya Bihari, AZP News. My question this morning is for Ms. Suchan. Ms. Suchan, you said that Trinidad and Tobago has a very robust and effective vaccination program. Can you tell us in terms of figures, annually, how many people have been vaccinated and for what they have been vaccinated for in terms of numbers? And my second question, maybe Dr. Hines might be able to answer, in terms of the anti-vaxxers movement, is that something that has prevented a large number of people being prevented from getting the vaccines in this country over the years? Thank you.
Ms. Suchan?
Thank you, Alan. Thank you for that question. And it's a really good question. And the answer for that is yes. Our coverage data, we do a percentage for all our vaccines. So our coverage data for vaccines for this year has been in the 90s. WHO recommends that we reach 95%. We may not reach 95% in all our vaccines, but our healthcare workers, the nurses out at the health facilities is working hard to get the population who requires the vaccines in, and we are doing exceptionally well, I must say.
Thank you. Doc, would you answer the question on the anti-vaxxer movement?
Okay, thank you for that question. The anti-vaxxer movement was more a foreign-based movement that has only more recently begun to pick up some support and pick up some steam, I guess, with maybe the advent of additional misinformation via social media. So we have not really seen a negative impact on our traditional vaccine pickup, vaccine coverage, vaccine uptake because of this movement in the past. We are hoping that by providing the correct information via the formal and official channels, that the information on what is really the situation with the vaccine will outweigh or outvolume the misinformation that is being spread by the anti-vaxxer and misinformation movement, and that will not have an adverse impact on our vaccine uptake going forward. So our population has demonstrated good sense and good prudence in its vaccine uptake behavior in the past, and we are hoping that it continues to do so in spite of the misinformation as we move forward into the future.
Thank you very much. We now go to the Express.
Good morning, Kim Mojram from the Express. Dr. Hines, I know some things are the domain of Ministry of National Security, but I'm going to go ahead and ask, as I know the health authorities are also part of those consultations and discussions. So a committee was to be set up to come up with an exemptions policy. Would you be able to share with us if that was done, if anything has come out of the committee? I don't know if the health authorities are part of that committee or consult with it. Could you tell us what's happening now with that committee? Thanks. And also, has there been an increase in applications for exemptions for the holidays? If you know what, Dr. Hines, that's part of my first question. My second question is, would you be able to give us an idea of how much foreign aid Trinidad and Tobago has actually received re-COVID-19, how much of it we've spent, what we've spent it on? Thank you.
Thank you, Ms. Boudram, for the questions. Again, your preface has answered your question. The deliberations of the Committee on Exemption will be provided, the outcome of that will be provided at a policy level by the relevant line ministers or by the Prime Minister himself as and when those decisions are reached. We are not in a position to make a statement on the outcomes of those at this point in time. Similarly, the foreign aid and the numbers of the increase in requests for exemptions fall outside the remit of the ministry and will not be questions that I will be able to answer at this point in time.
Thank you very much, Dr. Hines. We now go back to CNC 3. CNC 3, we are ready for you.
Again. Dr. Carrington, I'm just wondering something. I understand that ethnicity and culture for people does have a role to play in medicine. So I'm just wondering, with these trials that are occurring in populations that are predominantly white or Caucasian, would that translate to our population where we have a melting pot of different races and cultures?
Okay, so when you do a vaccine trial, you want to try, depending on the target, you obviously want to try to have as diverse a pool of people as possible. Some of the trials have been less diverse than others, and when we talk about diversity, we're not just talking about ethnicity, we're talking about age is an important one, gender is another one. So you want to have, basically be able to make conclusions about as wide a pool of people as possible. Some of the trials that have been done have been more diverse than others. And the trials, for example, the Oxford vaccine that was trialed in the UK and also in Brazil. There have been trials in the US. And so it's not just going on in the country that you hear indicating the vaccine is coming out of. The trials are disseminated widely. So some of them are more diverse than others. But it's an important consideration.
Thank you. Newsday, you are next.
Hello?
Newsday, good morning. Your question, please.
Hello?
You may ask your question. We are hearing you. Go ahead, please.
Okay, you're right. Quinn Chantak of Newsday. Question for Dr. Hines. I wanted to find out if the Ministry of Health has done anything with respect to the matter involving these persons who were involved in a THA finance team building exercise where it seems as if the COVID regulations were ignored. Have those people been quarantined, tested, primary contacts assessed, and that sort of thing? Could you answer that? And secondly, could you also give us an update as to whether there's been any development regarding this task force that the Minister of Health spoke about last week about that was going to be looking into enforcement of regulations re private and public gatherings? Thanks.
Okay, thank you for the questions. As we've said before, quarantine, testing, and other activities along those lines are initiated or triggered by the actual identification of a confirmed COVID case and confirmed COVID risk. So quarantine, testing, contact tracing, and other activities along those lines are triggered by the identification of a confirmed case and therefore the ability to assign different levels of risk and exposure to individuals so exposed. So in the absence of that, none of the above or none of the previously asked activities would apply or be relevant. With respect to the second question, the task force and the outcomes of that deliberation, again, that would fall within the remit of the minister to give an additional bit of information or update, and this minister, the relevant line minister, whether that be the Ministry of Health, the Office of the Attorney General, the decisions on any changes with regard to legal capabilities, again, lies outside of my ability to give a response at this point in time and would likely lie directly with the Office of the Attorney General. Will that be correct?
Yes.
Yes.
Okay, so we now go quickly to Wired 868.
Hi, thanks. One more question for Dr. Carrington, if I may. How would we know if the vaccine would need to be repeated in the way that, for example, the influenza vaccine is seasonal and we have to kind of keep going back every year to get it? What will tell us, or when will we know if the COVID vaccine would be similar in that we would have to come back every year and get vaccinated, or if it would be like one of those measles or yellow fever we got in primary school, you just take it once and you never have to take it again.
Okay, so that's a very good question. So something like the influenza virus vaccine, the reason why you have to keep getting repeated immunizations is because that virus changes over time. So that virus has a way of sort of mutating and recombining information with other influenza viruses, so that each year you get a slightly different virus from the year before. So, not always every year, but you get changes over time. So the formulation of the vaccine has to change. From what we know about the coronavirus, it does not operate like that. It seems to be relatively stable, so we don't expect to have sort of large, although coronaviruses can recombine as well, we're not seeing that sort of type of evolution occurring with the coronavirus. So most likely it will be a very, the same vaccine will work for all the variants that emerge. However, what the other side of it is the human response now. What we don't know a lot about is how long immunity to coronaviruses lasts. It seems to be at least, there's been evidence that the antibody levels, for example, wane over time. Now, this is through natural infection. So in people who have been infected by the virus, you will see their antibodies going down over time. Now, because your antibodies go down over time, does not mean that your immune system does not remember the virus, and if you get exposed to it again, it will mount a robust response. So we're still learning about how long the immunity lasts, but I don't think it's I doubt it's going to be a scenario where you have to be coming back every single year to get another vaccine. It'll be more about how many, you have to get boosters and stuff like that, have your first vaccination, and then you go and get a booster, and then so it'll probably be more like that. I don't expect it will be. But again, we're still learning. We've only known about this virus for 9 months now. Okay.
Thank you, Professor Carrington. We'll take one quick question and the last question from AZP News.
Hi, good morning again. I just wanted Ms. Suchan to follow up on the 90% rate. Is it that when you say 90% of the population has been vaccinated, is it the total population, or is it certain sectors? Is it certain for certain viruses, etc.? Can you just break it down for me so we can understand it better? Thank you.
Not here, no.
Okay. Now, Suchan, if you could just repeat your response, please. I don't think the audio was on. Suchan.
Okay, thanks, Al. So I was just trying to clarify the question he's actually asking. Is it all the vaccines he's talking about, or specifically school health vaccines? Which vaccines are you referring to?
All of the vaccines in particular, and what exactly is it on a total also.
Right. Okay. So basically, there are certain vaccines that we report to PAHO WHO every year. We do our coverage. And there are particular vaccines that we look for especially to report on. So that will be your vaccines like your polio, your DPT or diphtheria, pertussis, tetanus, your measles vaccines, and of course, yellow fever vaccines. We also report on the pneumococcal, and each of these vaccines, we have a target population, and we look at our children, birth to 5 years. So we report on those vaccines, and those are the vaccines that we want to monitor to make sure that the coverage is not going below 90%. Ideally, we are aiming for 95%, but we are really working to reach that goal. And that's where we work together with the general public. We urge parents to bring in their children to get these vaccines. It's very important. When we don't see these children, sometimes the nurses have to go home, go in schools to get these children. But basically, those vaccines that I listed there are the important ones that we monitor every year and we report on, and our coverage has been good with those vaccines. all in the 90s.
And we now stay with Ms. Sukchan, as she would now emphasize the importance of those persons who have not received. And we will stay with Nurse Sukchan, as she would emphasize the importance of those persons who have yet not gotten their vaccines.
Thanks, Al. So yes, again, we want to take this opportunity to urge parents. Our vaccination program is up, it's running. It has not been affected by the pandemic at all. We have not suspended this program, so we are urging parents to bring out their children. If you're not sure about your child's vaccination status, you can contact the health center. You can go in at the health center so that it can be rectified. We want our children out there to be safe and protected, even though we are in the midst of a pandemic. So once again, please, if you are not sure, contact your nearest health center so that your child's vaccination status can be updated if necessary.
Thanks to everyone. We have come to the end of today's media conference. As we enter the month of December, we ask that you please protect yourself and your loved ones during this Christmas season. If you haven't received your flu vaccination as yet, please get yours now. Contact your nearest health center for details. Also, please adhere to the simple guidelines that we at the Ministry of Health continue to reinforce. Wash or sanitize your hands and clean frequently touched surfaces. Maintain at least 6 feet physical distance from others and wear a mask when in public. Remember, COVID is not a gift you want to give or receive from anyone this Christmas. Goodbye for now.